Great. So thanks for giving us the opportunity to present our POCUS project that we ran over the course of a year and completed last year. So we had a great team working with us. So we had two very interested SHOs who helped us a lot with data collection and going through the cases. And Giza and Zoltan were very key in this quality improvement project, and it's a pleasure to share it with you all today. So my name's Jean. I am a newly appointed consultant in Oxford, and I have an interest in point of care ultrasound. So what I'm going to be talking about today is a bit about the background of POCUS for central lines. We'll chat a bit about our aims of the project, how we collected our data, the results we had, and how we've applied this to practice on our unit. So as you all know, working in an mostly for TPN, fluids, and medications such as inotropes. And traditionally, central line positions have been checked with X-rays, although there's increasing practice of the use of point-of-care ultrasound. So in particular, if the line tip position isn't in the right place, it's often quite fiddly and takes up a lot of effort from the team. And it's really important to maintain sterility when manipulating. If the line position's not in the right place, there's a lot of handling because of redressing, line removal, reinsertion, and repeated X-rays, and we all have experience of this. Additionally, if the line is not in the right place, there's an increased risk of extravasation injuries. And if the lines are incorrectly dressed, then there can also be infections due to line manipulation. So many of you may have seen these evidence-based guidelines on point-of-care ultrasound for central line insertion, written by Yogan Singh and from the EPSNIC group. And basically, there's increasing evidence that point-of-care guided line insertion and point-of-care ultrasound to confirm line tip position is actually very useful. In particular, the relevance is in reducing the number of X-rays needed and also reducing the number of line manipulations needed to confirm PICC line position. So the advantages of point-of-care ultrasound are if the line's correctly identified to be in the wrong place, line manipulation can happen in real time prior to dressing to avoid additional X-rays and to avoid extra handling. There's no radiation with ultrasounds. However, disadvantages are that people performing the ultrasound need to be adequately trained. It's very much user dependent. And as you can see in the picture below, if you have the probe in the wrong alignment, you can easily misalign. So it may be difficult to interpret sometimes. And with people who haven't got much experience in doing point-of-care ultrasound for line position, the scanning time may be longer, and with this there may be increased handling for patients. So this is a chart of all the things we did to try and establish this project, and so we worked very hard on this because there hadn't been practice of point-of-care ultrasound before. So first of all, we trained staff. So this was Giza, Zoltan, and I. And I'd just come from doing a placement at St. Thomas's, where I also picked up some skills in point-of-care ultrasound. So we trained interested trainees, primarily grid trainees, neonatal MTI fellows, and also nurse practitioners. Zoltan and Giza managed to purchase a new ultrasound machine with a microlinear probe, which is excellent for scanning upper limb long lines. And Giza managed to, with some difficulty, establish a new code on EPR, which took at least 6 months, I think, just to get this code so that we could link our ultrasound images to PACS. And so this helped from a clinical governance and documentation point of view. We also created a WhatsApp group so people on the unit could just put a text on the group to ask for somebody on the unit to come and scan a line. Also we held a couple of review sessions just to go through people's scans, and kept a logbook as well of all of the scans done, and worked with the clinical governance team in terms of identifying any extravasations with long lines. And our overall aim was to reduce the amount of line manipulations by 20% and x-rays as well by 20%. So this is the timeline. Overall, it took over a year to really establish point of care ultrasound on the unit. The first 3 to 5 months were in learning initial techniques, which probes worked best, sort of figuring out how we were going to collect data. And also our procedure performer had an extra category which included point of care ultrasound and what that showed. So then we spent a further 6 months training staff and reviewing scans. And what was really key in terms of helping point of care ultrasound for line insertion become a lot more efficient was that Zoltan managed to establish a Wi-Fi connection on the scanner, which meant we didn't have to plug in every time we requested a scan, and this made a massive difference, and really sped up the amount of time it took to get a line ultrasound done. So we did lots of interventions to get this project up and running. I've taken a screenshot here from our long line guideline. And one of the things we noticed whilst we were doing the project were that many lines were inserted too far. And this is because people were measuring from joint to joint to joint, rather than through a straight trajectory. And so our long line guideline was adapted in the middle of the project to try and reduce the amount of lines that were going into the heart. Additionally, we found that a lot of x-rays and ultrasounds weren't done with the limb in a standardized position, so it was hard to compare the position of the line and the position on ultrasound and x-ray. So what an additional point that we added was that we wanted upper limbs to be perpendicular to the chest during x-ray, and also for the leg to be flexed, the knee and hip to be flexed during imaging. So what we looked at were the number of x-rays to confirm PICC line position with and without POCUS. And it was tricky to define what was a successful POCUS, but essentially we decided as a group that the best way to define this was if a POCUS was successful, it meant that the line was manipulated and before dressing under ultrasound guidance, and also only one X-ray was needed to confirm position without any need to redress the line. We also looked at complication rates such as extravasation and central line associated infections. So we collected data from notes, Badgernet records, the PACS system at our hospital, which is called Insight. We also had a hardcover logbook on the ultrasound scanner, and anytime a POCUS scan was done, a sticker went into that book, and the details of the type of line, any manipulations or complications were documented. The clinical governance team also helped us to look through all of the reported clinical incidents, such as extravasations. And and so we started collecting the data. So to begin with, I'll talk about UVCs. And this is a picture of the venous anatomy. So when an umbilical line is inserted, it should go through the umbilical vein, through the portal sinus into the ductus venosus, and be in an ideal position, which is not in the right atrium. So in terms of UVCs, we had slightly less of these compared to long lines, and from our data, we didn't find any statistically significant difference between the numbers of X-rays needed. So overall, you can see that with POCUS, there were more babies having just one X-ray compared to more than one. And when POCUS was not used, there were more babies having more than one X-ray. However, this was not statistically significant.
Jean,
And
can
this
I
may
just...
be because we had quite a small number of babies. Sorry.
Jean, can I just add one thing for the audience here is
Yeah.
like, at that point it was, so we were doing POCUS in some babies with guidance, so under POCUS guidance. In some babies, just when the procedure was done, we checked the position with POCUS, and then we requested all time an X-ray as well. So all babies had an X-ray. And then the interesting thing was that it was a prospective, I don't know how we registered it, either as a quality improvement project or a prospective audit, maybe as a quality improvement project. And it was interesting that roughly half of the babies had POCUS. It was absolutely on the availability of the operator, and half of the babies didn't have POCUS. So it almost went as a randomized control study, obviously without any randomization, but we had babies with POCUS and without POCUS almost at equal number. And that's how you will see that you have babies with POCUS on a prospective time scale and babies without POCUS.
Thank you, Zoltan. Shall I just shrink this over, actually, and just give us a better view? So here, yes, so this is how we analyze the data. So we use a Fisher's exact test, and here you can see the p-value was not statistically significant. This is a graph illustrating how many X-rays were needed to confirm the final position. So with POCUS, you can see that there was a trend for more of a trend for a single X-ray compared to multiple X-rays when no POCUS was used, although this was not statistically significant. In terms of complication rates, we had small amounts of we had a small number of patients. And with POCUS, I think you can see that a number of lines were in the liver, and a number of lines were also not successful, so had to be removed. And whether or not this was related to POCUS itself is hard to say, because the sample size was quite small. So moving on to peripherally inserted central lines or long lines. I have an X-ray here showing a suboptimal position of a long line. So this line is coming in through the cephalic vein and is quite superficial. And this picture is taken also from our guideline, showing that when the line goes over the humeral head, it tends to have been inserted laterally, and so goes into the cephalic vein and can be prone to tissuing. So with our point of care practice, we used some of the training material from in terms of videos from St. Thomas's Hospital, and we also used the NICU POCUS website, which has great illustrations, as well as new videos which have been added on by Alan Groves and his team, as well as Jenny Koo from America. And with our guideline, what we defined as a short PVL, as I mentioned before, were lines that were inserted in a lateral vein to the mid-clavicular position, or a suboptimal line is also a very low IVC position. Or if the line doesn't advance beyond the hip or the leg. So on our guideline, what we have included is an anatomical picture of the venous anatomy.
Oh, sure.
And what
Where are they going?
Sorry? Sorry, Anna? Sorry?
It was nothing. I think it was just.
Oh, okay, yeah.
I think
No, don't
there's
worry.
somebody who forgot to mute themselves. There's somebody
I
who is
see.
who comes up as iPhone, so I don't know who they are.
I
But if
see.
they could mute themselves, that would be good.
Yes. Agree. So this is a picture of the venous anatomy in a human, and on the guideline we often mark where the line tip position is, which is quite helpful because lines do tend to migrate, and it's nice having a picture illustrating where the line tip is. So here you can see a lower limb long line, and the ideal position would be in the inferior vena cava, probably just below the cavo-atrial junction. So, so moving on to the data we collected. The PIC lines include both upper and lower limb long lines. And we had a significant amount of patients, so almost 100 that were done with POCUS, and 74 that were done without POCUS. And you can see that the number of patients who had a single X-ray was markedly increased in the group that had POCUS versus those who did not have POCUS with line insertion. In the babies who did not have POCUS for line confirmation of line tip, they were also more likely to have more than one X-ray. And I suspect because we had larger numbers, the result was statistically significant. P-value 0.01. This is a graph just to illustrate how many X-rays were used for PIC lines with POCUS and those without. And just looking at the general trend, you can see that when no POCUS was used, more X-rays were done, whereas a single X-ray was more likely if you had a POCUS scan. In terms of complications, again, there were quite small numbers and we couldn't really identify a trend. There were, higher numbers of lines that had an extravasation, but it was difficult to pinpoint any specific trends. We reviewed every single, all of the lines that extravasated. And it seemed like that for the ones that extravasated, they were not in an ideal position to begin with. So for example,
Have you had any chance to look at the cranial ultrasound in the lungs?
Not yet.
No, just she didn't say much about it.
Did they say anything?
She just said that she was.
Hi, can you all mute your microphones, please?
Even the brain.
Yeah.
Whoever is discussing a patient in the background can mute their microphone.
That's what she said. I just wondered if you had because I mentioned to parents that
Yes.
happened.
You have mentioned to the parents something. If you're happy about that, can we mute your microphone?
I'm documenting everything. Could you have
I
a
don't know
read
who
at
they
the
are
end
because
and see if you-
they are logged in as iPhone, so and I can't get them out.
Yeah.
I haven't been listening to the last conversation.
I just don't want to record anything. I'm talking on top of it because I just don't want to record
Yes,
anything
yes.
that is
Yes.
patient specific.
But
So
I
that's
think
why I'm
we-
going
I
mad
think
and
we can
talking.
support
Yeah,
you.
that's okay. I'll keep going then, Anna.
Yeah.
So then we looked at all of the lines that were not in the right position or had extravasated. And it looks like for the ones that did extravasate, they were not in the right position to begin with. So, so for example, this one, the first one,
But I mean, I'm
going
trying to
above
fix
the
it.
the humeral head. This one went into the internal jugular and was pulled back.
I'm not bothering that, but I just wondered for the A and B's.
And similarly, another one here, which went into the internal jugular and was pulled back. So 4 out of 5, 4 out of
to keep him a bit alive until they come.
Sorry, Jen, it's
4
really
out of
difficult for
7
you
of
to
these
carry on.
were not in the right
You know, it's good that they don't want that.
I mean, isn't it that on Zoom, whoever is the made the Zoom meeting can mute people, or you can't?
I don't
Give
think we
mouse,
can.
I'm going to
Ah,
give
but they
control to
finished,
you,
good.
Anna. Oh, no, that's to control the slides, isn't it?
Yeah, no.
Okay, never
Don't,
mind.
So-
don't worry, they finished.
Oh,
Ken.
it stopped,
Okay, for
okay.
whoever was discussing a patient a second ago, can you mute your microphone, please? Because I wouldn't want to record any patient-specific details you have been discussing.
Yes. Okay,
Yeah.
so just to recap what I was talking about, because it's a little bit noisy, we reviewed all of the scans that extravasated, and for the ones where POCUS was done, 4 out of 7 of them were not in the right place to begin with, and they were pulled back. So 2 of them had gone into the internal jugular and were pulled back, and 2 had gone from a lateral vein into the cephalic vein. So in summary, from the cases we reviewed, we found that POCUS actually helped to reduce the number of additional X-rays required for UVCs and PICC lines. Generally, there were fewer X-rays required when a POCUS for central line tip position were done. We did find some additional in the lines of the POCUS scan, but this has an uncertain effect because of the small sample size. So we had a fantastic team working with us, and everyone contributed to these scans. And these included consultants. Many thanks to Giza and Zoltan for training the staff. And then we had a few MTI fellows and trainees, grid trainees. So what are the implications for practice? So the positive things that came from this project were that we made the positioning of limb position for POCUS and X-ray uniform, and this was added to the guideline. Also, the length of long line, estimated length for long line insertion was standardized and updated on our guidance. We also created a EPR code, which meant that all of our scans could be recorded on PACS, which is great from a governance point of view. And also we had improved efficiency of the length at which it took to do a POCUS scan, because we established a Wi-Fi connection on the scanner. So we did find that the number of X-rays were reduced when POCUS was used. We also had a discussion with our lead consultant radiologist, pediatric radiologist, who reviews all of the scans on our unit, and they were very supportive of us using POCUS for confirmation of central line tip. From our practice, we also found that when UVCs are inserted, when they're in an ideal position on POCUS, they often look a bit higher on X-rays. And there's some published evidence which shows that actually POCUS is better than X-rays for confirming UVC and lower limb long line position. So some of the key learning points from our project include to make things smoother and to reduce handling for the baby was to find somebody to do POCUS before starting the line, setting everything up beforehand, making sure scans were not too prolonged, so limiting each scan to about 10 minutes. And the key tips from our own practice were that it's useful to estimate the line insertion length yourself when you approach the baby. If you're scanning the line, use multiple views to interrogate the line position. We found that the microlinear probe was better for upper upper limb lines, and the curvy linear probe was better for UVCs and lower limb long lines. And we confirmed the movement, the line tip position with movement and flush test, just to doubly confirm the position of the line. So as with most scanning techniques, the scanner's competence increases with the amount of line scans you do, and it requires a certain amount of skill and patience. Alan Groves has, there's some fantastic videos on NICU POCUS from Alan Groves and some US-based teams, and there is some specification of the amount of scans that you need to do to become competent. And here it looks like 20 scans for PIC and UVC lines. So it'll be interesting to see what the group's thoughts on this are. And there are also some additional training materials available from these videos. And I have, and we are just finalizing our guideline for point of care insertion. I'm just going to end it there. It's just over half an hour. Does anyone have any questions?
Thanks very much, Jean. It's really impressive work. I'm
just
not sure if there are any questions from others on the call, but what impressed me was actually the multiple drivers, I suppose, that you identified around implementing this, both around the technical skills and the training, but then the technology, the Wi-Fi connection, the logistics of doing it, wider acceptance within the unit, and communication as well. I think, the WhatsApp group and everything else. I think that's what I take away from this, that it's not just about the technical skills, it's all those other factors that you take into account.
Yeah.
Anne, I see Anne has his hand up as well.
Oh, hi. Thanks for the lovely presentation. Do you envisage replacing X-ray altogether?
Our radiologist has actually suggested that. And I think if you're absolutely confident, then maybe an X-ray can be delayed until it's needed for another reason. But I think from my own practice, I think, none of us have 100% success rate in terms of being able to confirm a line tip. And even, so we had an external speaker from Australia come and speak to us. What was her name, Zoltan?
Sherry Rogers.
Yeah, and she said, in her practice, she has missed lines as well, and it makes you feel a bit nervous just relying on an X-ray. Although there are many instances where you feel like absolutely certain it's in the right place.
Yeah,
I mean, I completely agree. We've been doing POCUS for lines for the last 3 years now, and I think as you said, lower limbs really we are in the position, at least at unit here, where for the lower limb lines, one can argue that you don't need an X-ray at all. I think upper limb is slightly still complex with head and neck vessels, but
yeah, but I mean, honestly, it's a really interesting discussion, and I'm a little bit sitting on the fence on this, but I already put my money on that. If you are certain, and actually, I mean, yeah, we didn't bring many ultrasound scans. Maybe we can dedicate another session when we will bring just the scans rather than the results and more the kind of governance thing. That there are so many scans when it is just absolutely clear where the line tip is. So we bought this 18 megahertz probe. It's a linear probe, small vascular probe, and Sarah is also on the call. She can add things. So I would say 4 out of 5 times it is very certain where the tip is. And the other thing which actually Jean Sarah taught me along with Giza was that moving the arm will have such an impact on moving the tip, which is also helpful, and also injecting saline. So I think with these, so where the tip is, sometimes it is just absolutely clear, especially with 2 French lines. to be honest, I think it is difficult not to be able to see where the tip is. But with one French, even with one French, with this 18 megahertz small probe, it is sometimes so clear where the tip is. Obviously, what you shouldn't forget that if it's a line, then it reflects back, so you shouldn't artificially create the tip by not getting the ultrasound, which is reflected from this very flat surface. Number two is I think the limb movement and seeing the tip moving is also very helpful. And we finally, I mean, it was our radiologist who suggested that, well, Zoltan, and I checked the literature. So in the literature, there are more and more data. So there are big meta-analyses demonstrating that actually the gold standard shouldn't be the X-ray, but the gold standard should be the ultrasound. And the radiologist kind of pushing us into this, no, guys. I mean, if you record it on PACS, if you see where the tip is, you move it. So, you know, you got 3 additional or 2 adjunct to say with confidence that this is where the tip is. What's the point of doing an X-ray? And it was a learning curve for us initially when we were X-raying all of them after the POCUS. And the POCUS was perfect position. We did the X-ray in the heart, or kind of, we don't even see. And then it took us a time to notice that the limb movement can have so significant impact. And the POCUS was done in a perpendicular arm. The X-ray was done in a, and there were really huge differences in where the tip. So practically what happened is we were chasing one method with the other one with not standardized limb position. And that's why you've seen, to me, it was a little bit of, I was expecting a far higher success rate with POCUS. So still, there was 20% X-ray rate after POCUS insertion. And that was, I think, mainly because we didn't standardize the limb position. So we were chasing limb positions by 2 modalities. And this is one thing, it's a revelation for us that we have to stop that. And number 2, now the radiologist is saying that if you have PACS recorded certain position, you don't need an X-ray. And to be honest, guys, the literature data suggests their view. But I'll leave others to.
And I think it was very user dependent. So for example, with Giza's scans, you know, all of the scans he did, because I reviewed every single one of these lines, his were completely accurate when he did them. So it depends on the person, you know, in terms of confirmation of the line tip. So we have Giza. We have also we've also started to put together a guideline, and just wondering if other people have different
Sorry, Jean, I think you're breaking down a little bit.
But
why don't we go through the raised...
internet.
It's okay. Why don't we go through the raised hands that I see on the background? Because I see the Bikash has a question. Then we can get back to you maybe.
No, congratulations for such a lovely project. And just in regards to a few comments in terms of the replacing the POCUS completely with ultrasound. I think so in adults and in big pediatric settings, a lot of places they don't, it's probably the POCUS is a gold standard and X-ray is almost replaced in adult settings. Most of the adult ITU, I don't think so they do X-rays at all to confirm their central line positions, and probably they have a benefit of larger body surface area and larger blood vessels where, you know, a little bit of movement won't impact. But we are in a 900, 500 gram babies, our bandwidth or safety net is very, very low. So I think so it needs to be more careful. But what would be interesting to see what if units across the country are the units which are stopping to use X-rays completely and what the complication rates are. But what we have started doing particularly is babies who have central lines, particularly for a long period of time. What I do is I just reconfirm their positions after 7 days, 8 days, particularly with the UVC. If I see that the UVC is going to stay for longer, with an ultrasound to see just, is the central line in a decent place and it is not been, the positions have not moved, instead of exposing these babies with an X-ray. So that's what I do. But probably it is other problem is that to replace it completely, we need all the almost all the staffs who are putting central lines to be skilled to able to do POCUS. Probably it would be more, I would say it is better to have a standardized practice that everybody follows, rather than at places you're doing X-rays and because the person is inserting is confident, and other times you don't do X-rays. So that's probably the care is not consistent. So that would have implications on your long-term NICU care. Actually, that's what I would say. Another thing I was saying was, did you look into the time from insertion? So probably one thing where will significantly impact is your time from you're putting time to start the process to the time of starting your PN. That would be another outcome which could be measured in terms of not only the X-ray exposures, outcome which could be measured to see the benefit of POCUS.
That's definitely a very good point, and we would have liked to include this, but we didn't have that data. So we have a draft guideline. I wonder if you'd be interested in looking at it briefly, or maybe we can chat.
Jean, can I just ask? Oh, can I just ask a quick question? So I'm hello to everybody. I'm Sarah. It's the first time I've managed to join this. I've recently joined Jean in Zoltan and Giza in Oxford, and hopefully POCUS is going to be part of my role. The one thing which we've been talking about, which would be interesting to hear from other units who've introduced this and try to train up other trainees, is what are your standard views? So there's the interest of time. How many views do you take? Do you standardize what views you take? We've observed that different practitioners in our own practice, some always find it, but how long they take to do that? And do your guidelines, which you already have in place, have a standardized set of views? And do you have a limit to how long you can try for? Because I think if you're trying to train a lot of people who aren't used to echoes, we all come from echo background, generally all of us who are doing this line POCUS, trying to teach these views, it'd be nice to share the experience other people have had of working out exactly which views you want to use.
Yeah, so the practice at St. Thomas's, where they have some published videos, so that, and the NICU POCUS website and Ellen Gross and Jenny Koo's group have the same views that we use. And also we've had experience of doing these scans for over 2 years now. And if I just show the so I got in touch with Jenny Koo in the States, and she's a medical illustrator and was happy to share her illustrations with us. So we won't go through all of the nitty-gritty on the guideline. But basically the on the guideline, a picture of the probe position. Sorry, my internet's not very good today. And what they have, which is quite nice on here, is a sort of ideal position and how it correlates with X-ray. So that's quite useful. And similarly for upper limb lines. And she has pictures like this showing where you put the probe on. And in terms of training, I think we do have to be careful on who, we do have to be careful in terms of how we adapt clinical care according to what we see on the scan, because not all trainees will have the same competence in terms of doing line scans.
Anna, you wanted to add something, and yeah, but I mean on this very interesting thought in terms of how you train the trainees are you coming from a more cardiac views are in, this setup, because I think it makes immediately much more difficult rather than you just go POCUS and the vessels as Sarah described. I'm tending to go with Sarah views on this, because as soon as you come in, so when we started, I sent across to the consultant team those description what Alan put together on the NeoFOCUS website, which I think is very good, provided you have some experience with cardiac scannings. As soon as you don't, those consultant colleagues of mine who read it, they just found it very difficult to follow what views, subcustal, this, that. So I think we need to make it much more simpler and much more easy to follow. And then it's obvious it's a bit of a governance point that do we want standard heart scans on these, or if you can identify the tip in upper extremity limbs, and sorry, I wanted to say subclavian, but kind of above the heart veins, is it sufficient enough, or do you want to record absolutely normal right atrium, right ventricle pictures and loops not having line in? And then it brings up the how easy to generate this reverberation artifacts. So I think that's obvious. It's another kind of worm in terms of which it brings up. But unfortunately, because we are kind of doing and trying to find the good governance, a solid governance around this, is just it's an elephant in the room what you really neglect.
Yeah. So shall I just describe what we do, and people can say whether they do something
Anna, you
different?
wanted to say something, and Neil.
Oh yeah, thank you. Just to congratulate again Gina and the team for what she presented just now, and especially for some of the aspects like the Wi-Fi and the link to PACS. We are at St. Thomas, we're still working hard to get the images to PACS. I'm still saving the images on a flash drive and then storing them and then going crazy. So well done, really amazing. I think I would agree with the idea that we should standardize a little bit better the images that we take, and particularly for the SVC or for the upper limb long lines view, because I think that's a tricky one. Everything else is, if I can do it, everybody can do it. But the SVC is a tricky one. I was wondering if I know you were going to talk about that, but if you wanted to share the position of the probe or the images that you get, because I was also curious about the fact that you're using a linear probe for that, which to me, I've never tried with a linear probe. It was a bit different.
Yes.
And again, talking about the limb position, one of the questions that always comes to my mind is that, okay, I can decide in which position I keep the limb when I do the ultrasound or the X-ray, but the baby is moving. So will I then choose to secure the line a position in which is, I'm sure they will never be in the deep in the atrium, whichever movements the baby does, or shall I just choose a position? Because sometimes if you lift the arm up, the line goes in, and then you are risk of tamponade. But at the same time, in the same baby, if you pull out the line to avoid that, every time the baby has his arm down, the line is going to be in a peripheral position, because we are talking about little ones. So what is your practice? Do you find like a gray area, middle ground, or do you check both the most in, the most out, and then you find something in between? I don't think I have an answer for that, but if you have one, tell me.
Sarah also had this issue. Sarah, would you share your views? Because we just recently discussed this.
Yeah, I mean, exactly. We had that extreme is a 350-gram baby, so the real extreme, but literally moving the limb, it went right into the right atrium and right out to the periphery, and it actually flipped up into the carotid at one point. So there is no right place for those babies, but I think we have to be mindful that I think that this brings into the idea of having to rescan, and it's something which I've been trying to sort of do on the time I have, is to actually rescan every 2 or 3 days all the lines that we have on the unit to make sure they are still where we expect them to be, and that they haven't migrated. I think that's one of the big risks in these little ones, and handling the cares of the babies, just being mindful again for these very small ones.
And talking about scanning, repeated scans, we have been reviewing our UVC's positions after 2, 3, 4 days. And actually reviewing the literature as well on the topic. Usually the time at which a UVC moves around the spikes, an initial perfect position is usually around 3 to 4 days. So we have decided that we will always scan the UVC at insertion, but then we scan again at day 1 and day 3 and then day 5, because we just feel like there's a risk if you leave the UVC there. And I heard that, who was talking about that before? I can't remember now. Was mentioning scanning at 8 days. Maybe it was Vikash, was it? Were you mentioning that? I'm just a little bit worried that 8 days might be a little bit too much. You might want to have an interval review at 3-4 days. Sultan.
Yes, I mean, when we were, so we noted how much difference to the line position, the arm position can make. We wanted to we standardize, and finally we agreed that I think the best would be to record the line position in a kind of neutral position where most of the time the baby will have his or her extremity. It's sometimes difficult. So either you go like fully abducted or fully adducted or abducted. And finally, we agreed on 90 degree. However, the problem is depending whether the line is coming more medial or lateral, unfortunately, so they can have exactly opposite effect on the line. So it is, I mean, if you read the St. Peter's and Chertsey, put it in that way, that lines which are coming lateral need to be standardized this position. But I think it just makes it so difficult that finally we decided, and what actually Sarah is doing now, that we image the lines in 90 degree, but then we rescan in 2 to 3 days, because there is certainly a movement of these lines. We actually see it, and that this project was a bit of an eye-opening to us in that regard, that we never re-x-rayed the lines, despite the fact that when we had a discussion a couple of years ago with Paul Clark from Norwich, who was one of the lead author of the BAPM central guide and central line guideline, he told us that, guys, I mean, we are re-x-raying these lines because they are moving. So just because at the time of insertion they were in a good position, there is no guarantee that in 3 to 5 days time we'll do. And they were routinely x-raying these lines. And we felt that Sarah now on the unit and coming 3 times a day, and her role is to do echoes and also line focus. So this is our plan, to see how much movement these lines are doing. And we feel this would be a kind of good safety net to refocus these lines, UVCs plus PIC lines. Every line needs to be refocused in 2 to 3 days time to see the movement.
Vikash.
Yeah, I completely agree with you, Anna, that we need to check the positions of the lines. And probably, it is very much like whether you check it with X-rays after a few days or you check with the point of care ultrasound. But most of the time, these babies who are extreme preterm, they end up in having X-rays for whatever reasons, tube positions and all. So what I was trying to establish is whether you would replace the point of care completely and not doing X-rays at all. Particularly for at the time of insertion, I would it's difficult, I would say, just because of the body surface area and the various skill match, and to have a standardized practice. But definitely I completely agree that for reconfirming the line positions after day 3, day 7, whatever it is, just like we do head scan, would be nice practice to establish. I don't know. It's very nice to know that you guys already put that in place in your unit, that you reconfirm the line positions. But that would need by point of care, but you need a very skill match group of people, at least 4 or 5 people, because the way we work, we change around, is for people to come around and, so that we have a practice in place that happens to each and every patient, despite of the clinician cover. And so it's not about not dependent on the user or the consultant on the week who's providing the service, because then some patients get those confirmation, others won't get. So then again, there is inconsistency in the practice. But I completely agree that we need to reconfirm.
Sorry, Vikash. So that's where Sarah has a 3-week role, so is able to regularly scan these lines. So I just wonder, if we have this group on at the moment, just wonder if we could pick your brains about what you do in terms of standard scan views. I know we're sort of closing up now, aren't we, Neil? Maybe, do we have time for that?
Yeah, maybe you want to, we can do as a show of hands, Jean, if you want to ask.
Okay, yes, great. Okay.
Maybe in a kind of.
Yes, perfect.
As a question, you can sum up.
Okay, great idea. So for lower limb lines, it's quite standard. Do a sagittal view, just under the diaphragm, looking at where the line comes in to the IVC and whether or not it's in the right atrium. Agree? Does anyone do a subcostal view of both the atria, just to have a look in another view? No.
I do that actually.
I do sometimes as well, but yeah, it seems like it's not that standard. And for upper limb lines, I usually measure the length.
Extremity. For
Sorry?
for
That's
lower
for lower extremity.
I use from the sides. So I don't try to scan through the bowels because this is extremely difficult. So what I do is go to the kidneys. So how you would do a kidney scan, I always do to the flanks, and then I do it from laterally and through the kidneys. It is with a linear probe. And many times I use not the 18 megahertz small probe, but the bigger one, the fat, big 9 hertz long. You put it on and practically you see everything in abdominal aorta, IVC is just so easy to visualize. And with a nice 8 hertz or above linear probe, one French lines are just so easy to visualize. And if you see it and the tip position is clear, I don't go subcostal and any additional auxiliary views. So many times I just do one lateral through the kidneys for lower extremity one, but that's my practice. So I don't know.
So I think this is what's on the video as well on the NICU POCUS website. And for upper limb lines, I tend to remeasure what people have measured, not because I don't trust them, but just so I know where the line tip is going to sit. And then have the arm standardized in the perpendicular position. Do one sort of subclavicular view, and then one parasternal view to look at where it is in the IVC.
Yeah, I do that.
People do the same? I know, Sarah, you do the same, don't you? And then if you cannot see the line tip clearly, we sometimes scan the other side. Does anyone do anything more than that?
Or the neck.
Or the neck. Does anyone else do more than that?
I also do, particularly for the upper limbs, I also try and, after also do a subcostal bicable view, just to see whether I can align the IVC and SVC together. So just to see whether I can see the lines in the SVC and whether it is crossing the SVC turbation valve RA junction and it is impinging the right atrium.
And do you use a cardiac probe or a linear, or?
For that, I use a cardiac probe. There is, won't be able to see because right atrium is right at back. So we need, so you just get an atrium.
Our linear probe is just so difficult to do these views that I stopped doing them.
And I think people struggle to do that view.
And we don't have cardiac probes on our POCUS machine.
I think we do, don't we, Giza? We do.
I thought we just had, we put a new one on. I didn't last minute. Okay.
I have a question, please. Yeah.
Thanks, Jemima. Yeah.
Okay. So first of all, we all for the PIC lines, we do measurements and then insert the lines. But it seems like many lines, they are not, the tip is not as expected by the measurements. So this discrepancy between the measurement and by where they lie, how to sort this? If we use the probe, the ultrasound or the POCUS to measure like, the trajet or where the veins, where the injection point or the insertion point and the heart, would we have sort of anticipation of the measurements that we use and see if this will improve the insertion? I mean, the tip of the PIC line in the right position or not? It sounds a bit strange, but did I manage to?
I think. Yeah, I think it makes theoretical sense, but may take quite a long time to do in practice. So I think academically, I think you could measure the length of the veins with ultrasound, but it would take too long.
And you can do sort of centiles and probably in advance rather than just blind measurements. I think I have something actually I would like to share. It's just the boundaries of applying the POCUS. Okay, so myself, I used to practice where the tip of the line by POCUS in 1997 in my training in France. And then I stopped doing this for years. And now, or for the last few years, I think there are a lot of boundaries in each unit, because not in every unit you have a radiologist who is really cooperative. We don't have a standard, we don't have a legislation of the use of POCUS. Even if I do anything or like lung ultrasound, pneumothorax, etc., it's just because there is no legalization of the standards. So I think until it becomes part of the PAPM guidance, there will be a lot of difficulties for many people to practice that in a standard way. So how you manage to make it, a legislation for the use of POCUS, because I think this is a major issue, and a lot of people, they are facing also the resistance from not the old consultant, like some of the older views, like, oh no, I want X-ray, because they will not. So you find yourself really in trouble. So how you manage to overcome this?
I think it is one of the main aim of this group, to be fair. The fact of reaching a consensus among us who are more interested in the use of POCUS, and we are the believers of POCUS, because we have seen the evidence of the result of using POCUS in our patients. And one of the aim is then to involve other organizations, including BAPAM, and go there and say, okay, we have the evidence, we are developing the skill set. We need to make sure that this becomes normal practice. And this should also be included in the training for our trainees, pediatric, especially in neonatal training, for what I'm interested into. And regarding possible litigations, yes, it is true, because at the moment we don't have clear evidence. What happens if I decide that a line is in a good position, I don't do an X-ray? At the same time, if you have seen some of the recent publications about litigations around POCUS in the US, where the litigation is quite a big issue, they actually don't have that many. And there are not a lot. There are not litigations around POCUS in neonates and decision making based on ultrasound. So that's a little bit reassuring, but it's definitely something we need to work on. I hope you all agree.
Yeah, absolutely. I think this group is a great starting point, and the work this work is spearheading it, and the evidence that people are gathering. And I suppose one of the ongoing questions is going to be, how do we work collectively to continue to build that evidence base that can then translate into a national guidance. I'm conscious of time, and I think it's been an absolutely fantastic presentation and discussion, and almost certainly a topic that we should pick up again in this group. And as you suggested, Zoltan, maybe next time as well, it'd be really interesting to see some of the images you're using and collecting. And
yeah, absolutely.
Yeah.
So we can bring images.
I had a slightly provocative question, maybe not for an answer, but something for us to discuss down the line, which is, I suppose, if we want to create capacity in our units for this to be done routinely, including the reassessment of line positions routinely, then actually, I'm reflecting in our own unit, who are the best people to train to do this? And of course, if we train trainees, we create, of course, a cohort of neonatologists in the future who are going to have these skills. But selfishly, within individual units, I'm interested in who's going to stay in the unit and do this. So I wonder whether our nurses and our NNP colleagues are potentially people who we should train. Not all of them, but maybe some interested ones. So yeah, I'd be interested in other people's thoughts on that.
I have trained the ANNPs, and I think they understand the theory, but I think they feel a lot of pressure in terms of taking the risk, in terms of saying, oh, the line is in a good position, I'm happy to, because it feels quite onerous, I think, taking that risk on. So perhaps there's been less uptake because of that.
Yeah,
but I think there's more scope for training them.
And maybe just to attract them to the use of ultrasound, because they already do cranial ultrasound, at least in our unit. Some of them are starting doing lung ultrasound. When they build up confidence in their ability to scan whichever organ, whichever thing, and they kind of orientate themselves better, and then they see the result of their scan being implemented in the clinical practice. I think that is kind of a stepwise approach that might help.
Yeah.
We have a raised hand. Sorry, Giza.
I just wonder, whoever does among you in terms of practice, what do you put the line in and then you start checking the position, or do you actually do the scan while the line is inserted? What is what you...
No, I do it at the end, especially for long lines or for long lines. I do it at the end when the line is inserted, then I scan. For the UVC, UAC, usually it's kind of a contemporary thing. So once the line has gone in, then I scan it before it's secured, essentially.
Because I'm just wondering whether we would have a better chance to position them well if we would do the scan while the line is inserted and we actually see the line coming into the subclavian, because that's the best position to see the line. I haven't done it, but while this discussion, I just thought this may be a better position, and it may be easier for ANNPs as well to learn that, you know, you see the subclavian, you see the line in, it's in it, you can leave it there, rather than we put it in and we start searching. Because what like others said, the problem is that if it's too deep, it's often, I mean, I often miss it in the heart. That's the challenge, and I rarely ask them to 4 centimeters until I see the tip definitely in the subclavian, and I ask them to push it back in. I don't know what others.
Yeah, which is one of the things that Jim was mentioning, the manipulation of the line, pulling back, pulling in until you actually see the tip. I think sometimes it takes a good amount of time to get the line in. So if you have one operator doing the line, one holding the baby, and a third one doing the scan and waiting there, the baby's not going to stay still. And also you have an extra person. So staff-wise, I don't know if you have enough people.
Yeah, Giz, I mean, this would be an absolutely great project for a small research, even like, you know, this way, that way, randomized.
I think so.
And demonstrate that we can
look at that.
how many lines need manipulation, how much you can reduce the X-rays. So such as like these, yeah.
And also ultrasound guided insertion of the needle itself and the line itself. You know, that's the next step.
Okay, but we can dedicate another session to pick lines and also to UVCs, and we will bring in a few scans of ours, and then probably everybody will have, oh yeah, I have similar like that. I've been there. But I mean, yeah, what Giza is saying actually, yeah, that's visualizing in the heart, I think, is just very tricky. So yeah, visualizing in the subclavian brachiocephalic is okay. As soon as it is SVC, where optimal line position should be. But if your unit is happy to keep it beyond the midline of the clavicle, the subclavian, which we are happy, there might be differences whether you want them right in the SVC. Obviously, if you are not happy with the subclavian position, you want to push all of them into the SVC, then I think it becomes a bit more tricky. Okay.
Great. So it looks like we definitely want to have more sessions about ultrasound of the lines, and maybe we can have one, I don't know, maybe one where we share some videos and some of the lines that gone in random places.
I will put some together. I was planning to have some at the end of Jean's presentation, but I didn't have time to put it together, but I'll put some a few images together.
Thanks, Giza.
Amazing.
Thanks very much, everyone. Really great discussion.
May I request you to share your guideline, please, on the group? It will be very useful for if it's possible.
We'd love to. I think we're just finalizing it.
All right. Okay. Whenever it is.
And if you put your email in the thing, I'll get in touch with you.
All right. I'll put it in the group actually, so for people who are. Thank you.
Bye.
Great. Thanks, everyone. Have a great weekend. See you later.
Bye-bye.
Thanks, Jean. Bye.
Bye.
Thanks.
Doesn't mean that if the consultant is working, but let me just find instead of.
Hi, sorry to keep you waiting. What's everyone's date of birth so I can pull it up on the system? 17/6/22, and it was Copeland, you said the last name was it? Perfect. I'll just be a second, I'll come back to you. Thank you. 17/6/22, everyone Copeland.
17. It's not in here, yeah, even.
Is it Evelyn Copeland?
Yeah. So what, let me just open the discharge summary. So what were the bloods, why they wanted to. So she was a 10 baby, transferred from Peterhead, postnatal ward, kind of respiratory distress. Then she went to postnatal ward, and then probably now I have to go to maternity to say what swabs were needed for her. I don't know what it is. What are
Speech console there when you're ready.
this one?
Yeah.
Hello, hi there. Hi, it's Dr. Consultants. I'm speaking to you. Are you looking for some results? Can you tell me which results for the for? All right. Okay. All right. Fine. How is the baby? Okay. Giving you. I know. And you have got your head them at home, isn't it? Yeah. I am just looking into the blood results. They're negative. Okay. So, yeah. Forward infection. Yeah. So. So normally when the baby, so was she delivered by section or normal delivery? Okay, so it basically depends for what reason they were developing respiratory distress. So you can never, and we know that when I'm looking at her notes, there was some meconium. So the meconium can make the baby work hard a bit if they have inhaled it. But she settled very quickly on some CPAP, and it was not infection, which we were basically thinking. So all good, and now the blood culture final result is all okay. And when I can see into your group, her infection marker was never high, and her full blood count was okay. So it seems that it was just maybe some meconium delivery, and their lungs were a bit collapsed, so they needed to be expanded. But the baby's clinical event, so I would just ignore every clinical detail, just go with the baby. Baby's clinically okay, so that's it. Okay. Okay, thank you, bye. See, this is something which these people, come on. I didn't know this baby. Next time.
I asked 1, 2, 3, 4 people. And then so you're the 5th person. I asked to speak to him.
Oh no, that's fine. I'm happy that you came and then this.
But you could have done that.
Yeah, just like going to. So thank you. And then see my circumstances is as I was saying, and it's not a problem to get some lessons initially with someone, but because my friends are quite busy and they can't give me some time to be with me and to watch my driving. I will be paying Stewart for whatever when he's sitting with me. You know, when you have to have a person sitting next to you who has had a license for 3 years. That's the reason. Yeah. So
he said anybody just have, I will speak to him.
Yeah.
I
So
think he's home tomorrow.
yeah, whenever, because now he's going to send me the.
Him and Norma went to the concert. Do you remember Norma?
I know.
Yeah.
She's very good.
I will speak to him.
Thank you.